Got atrial fibrillation? What's your score? Atrial fibrillation is the most common cardiac arrhythmia worldwide in both inpatient and outpatient settings. And with it comes an increased risk for thromboembolism, which may lead to an ischemic stroke. Due to this increased risk, it is important to manage these patients adequately with proper anticoagulation therapy, as antiplatelet therapy is no longer recommended. With this being said, anticoagulation is not without its own risks, specifically bleeding. The most notable at risk group being the elderly, who, at the same time, are more likely to benefit. The question then becomes, how do we stratify these patients' risks? Are they high, moderate, or low risk? And is long term anticoagulation therapy of benefit to them? The CHAD-VASc score helps determine the risk for thromboembolism and does so by incorporating important patient indices and creating a score. This number then correlates to a patient's risk of thromboembolism secondary to atrial fibrillation and the need for oral anticoagulation treatment. However, it does fail to account for the risk of bleeding. That is why we have the Hasbled score, which is calculated to assess the patient's bleeding risk. The Hasbled score takes into account other important factors such as hypertension, age greater than 65, stroke history, renal disease, liver disease, prior major bleeding, labile INR, use of aspirin, clopidogrel or NSAIDs, and alcohol use. It then stratifies their risk of bleeding, and the physician can make an appropriate decision for anticoagulation therapy. After calculation of both the scores and a discussion with the patient of the risk and benefits, an informed joint decision for long-term anticoagulation can be made for the prevention of thromboembolism from atrial fibrillation. Now we move on to our case. Here we discuss a 74-year-old male with an extensive past medical history who presented at the clinic for a cardiology follow-up for atrial fibrillation. He has had atrial fibrillation for quite some time, but has not been willing to take oral anticoagulation treatment. 2 months prior to his visit, he presented to the ED for constipation and was told again to seek treatment for atrial fib. The risk and benefits of anticoagulation were discussed with him there, and he agreed to treatment. He was prescribed Eliquis and has taken it consistently since then. Patient has continuously denied any chest pain near syncope, orthopnea, or paroxysmal nocturnal dyspnea. He, however, does endorse spells of dizziness and lightheadedness that's associated with this flutter in his chest, and shortness of breath with walking. However, he's still able to continue walking and carry on with his daily activities. He has not fallen or felt unsteady at any time. Physical exam only demonstrated an irregular rhythm with no gallops or murmurs, and 2+ pitting edema in the lower extremities. His vital signs were within normal limits. EKGs demonstrated atrial fibrillation with RVR. His CHAD-VASc score was 3, indicating moderate high risk, which is an indication for anticoagulation therapy. He also had a Hasbled score of 1, which places him in the patient low risk category for bleeding. With the patient presentation and the scores in mind, it was decided to continue this patient on Eliquis as long as he can tolerate it without any adverse events or risks of falls or injury. He will have routine follow-ups as necessary, both in cardiology and anticoagulation clinics. Now for our discussion. In atrial fibrillation, one of the most concerning sequelae is an ischemic stroke due to a thromboembolism when one is left without anticoagulation. The risk of stroke varies based on individual factors that are included in CHADS-2 and CHAD-VASc score. CHAD-VASc score allows fine-tuning of the CHADS-2 score in the lower risk group. The CHADS-VASc score has a total highest score of 9, while the CHADS-2 score has the highest total of 6. The CHADS-VASc score incorporates 3 additional categories: sex, age between 65 and 74, and vascular events. Both methods recommend that the low-risk group of 0 does not require anticoagulation, where in those with CHADS-VASc score of 1, it is controversial and requires discussion. And lastly, with a score of 2 or greater, anticoagulation is required. However, the Hasbled score may sway you otherwise. The CHADS-VASc score aids in further decreasing the intermediate risk group by 20% and placing more in the high risk, most notably women and those with peripheral vascular disease. With this shift, the number of patients being treated with anticoagulation has also increased. This is justified, however, due to the risk of thromboembolism from AFib outweighing the risk of an intracranial bleed in most individuals. The CHAD-VASc score also does a better job at identifying low risk patients. The CHADS2 model labels many patients as low risk when some anticoagulation will still benefit this group. A meta analysis performed by Chen et al. Demonstrated that the average incidence of thrombotic event in the CHADS-VASc low risk group was lower than the CHADS2 low risk group, 0.4% versus 0.94% respectively, with a p-value of 0.026. With this increase in allocation to the high-risk group, bleeding risk also increases. This is where the Hasbled score becomes a risk stratification tool to predict an individual risk of bleeding. A study performed by Gorman et al. Demonstrated that in a group of patients on rivaroxaban, the group that had an episode of bleeding also, on average, had a higher Hasbled score, 3.13 versus 2.58 respectively, with a p-value of 0.035. This signifies that the Hasbled score can be adequately used to assess a patient for bleeding risk with anticoagulation therapy. However, a high Hasbled score alone is not a reason to withhold anticoagulation therapy. A physician and patient must make a fully informed decision based on the patient's clinical presentation, including but not limited to history, physical examination, and ancillary studies. These calculators, CHADS-VASc, and Hasbled scores are available online and are tools to be used in the aid for decision making. In conclusion, CHADS-VASc score identifies low-risk patients and has the benefit for foregoing long-term anticoagulation, while some with intermediate risk using the CHADS2 model would be considered as a candidate for anticoagulation based on CHADS-VASc score. The use of the Hasbled score assesses patients' bleeding risk and may make the physician and patient decision to start anticoagulation or not more justified. The Hasbled risk can vary and would allow the physician and patient to monitor the risk of bleeding even after anticoagulation has started, making it easier to discontinue anticoagulation as needed. In conjunction, these two tools have now become an invaluable asset to the physician treating patients with atrial fibrillation. The question I pose is, why not just place patients on some anticoagulation, even a low dose if they have AFib? As physicians, we have this innate calling to fix everything, thinking that if we can fix it, why not do so? The problem in this case is that the treatment isn't benign either. If we had treatment with zero risks, then by all means we should prescribe it. However, in a patient with low risk of thromboembolism, placing them on a blood thinner has the ability to cause bleeding, whether it be minor, major, GI, or the most feared intracranial bleeding. You just increased that risk. For example, let's say you have a 45-year-old active male who has AFib and is at low risk for thromboembolism. Would you anticoagulate? Probably not, right? And the reason for that is if he falls while running or hits his head while playing basketball, for example, his risk now for an adverse event due to bleeding has exponentially increased. So for this reason, being judicious in how we treat a condition is of utmost importance. Acknowledging that a treatment can cause more harm than the disease itself can make an impactful difference in a patient's life.